Hi, so today we will be discussing about stimulation protocols in ART. Stimulation protocols are very important in ART because one size does not fit all. So we cannot apply a single protocol in all the patients. So that's why to understand which protocol suits for best for the patient is important, and what those protocols are. That's why I have made this presentation to make it easier to understand. So, why do we need controlled ovarian hyperstimulation? So, this is the first question. Why do we need that? So, controlled ovarian hyperstimulation for IVF is to produce multiple follicles. As the more the number of oocytes, the more the chances of conception, because the more the number of embryos will be formed, and we will have more chances for the frozen embryo transfer. Secondly, because if we have to do further the pre-implantation genetic testing, definitely we will need more number of embryos. So that's why controlled ovarian hyperstimulation is important, and to allow a selection of embryos that can be replaced into the uterus. So the probability of having a pregnancy increases as the number of oocytes increases. So that's why we need controlled ovarian hyperstimulation. Secondly, why we need pituitary suppression? Because we have to give pituitary suppression either with GnRH agonist or with GnRH antagonist. If we do not do that, 15 to 25% of the cycles will have premature luteinization. Okay, and that will lead to abandonment of the cycle. Then what the controlled ovarian hyperstimulation steps are? The first step is, firstly, the hormones should be at the baseline. The second is to stimulate the ovaries so that multiple follicles form. And the third step is, when the follicles become mature, the ovulation trigger is given so that the uterus is also prepared for implantation if the hormones level remains normal. So these are the three steps of controlled ovarian hyperstimulation. So we will discuss all the protocols one by one. The first and foremost is the GnRH agonist protocol, which we will be discussing. But before that, in a simple way, I will be telling you what these protocols are. One is the GnRH agonist, which can be long, short, ultra short, microflare. Shortly we will be discussing these. And GnRH antagonist can be fixed and flexible protocol. For stimulation, there are gonadotropins which are used, and there are oral ovulogins also we can use. Gonadotropins can be recombinant as well as urinary products, and it can be HMG, which can be highly purified urinary. And then there is a combination of recombinant FSH and recombinant LH, that is the pergoveris. The oral ovulogins like clomiphene, letrozole, they can also be added, especially in the random start protocols when we are using for the cancer patients, especially the hormone sensitive. Those cases, letrozole is an added advantage because it decreases the estrogen levels. And then finally, for triggering, we can use the HCG, which can be in the urinary form or in the recombinant form. And secondly, we can use the GnRH agonist, especially in the women who are higher responders, or the PCOS women, and the oocyte donation cycles. We are using the GnRH agonist, which can be in the form of leupride 1 mg or triptorelin 0.1 to 0.4 mg. Then coming on to GnRH agonist. What GnRH agonist is? We all know this is a decapeptide because it has 10 amino acids. And how does it work? It works by, initially the GnRH flare up happens because of the sudden release of the FSH and LH, and then followed by the pituitary suppression over the around 10 to 14 days. Then what are the protocols? It can be the long protocol, which can be follicular and luteal, short, ultra short, and microflare, and there are various preparations, but most commonly used is the leupride as well as triptorelin. Rest preparations are also there, the buzurelin, nefarelin, and gozerelin. The protocols which are recommended by the guidelines, the recent 2024 guidelines, that are the only long protocol. The guidelines are not recommending the short, ultra short, and microflare protocols, but we must know what they are. So coming on to first, the long protocol, the follicular start protocol. In the follicular start protocol, as we can see from this image, we are starting the GnRH agonist from day 2 of menstrual cycle, and then the gonadotropins are started once the pituitary suppression happens. So pituitary suppression happens usually by 14th day of the agonist treatment. So roughly around 10 to 14 days are required for the pituitary suppression to happen, and after that we can start the gonadotropins. Now how will we come to know the pituitary suppression has happened? We can do a battery of blood tests as well as the ultrasound. The blood test, there is a rule of 5. If the LH is less than 5 international units per liter, if the estrogen is less than 50 picogram per ml, and if the progesterone is less than 0.5. So all these are suggestive of pituitary suppression. And on ultrasound, if we are not seeing any big follicle more than 10 mm in the either of the ovary, and if the endometrial thickness is less than 5 mm, so these are all suggestive that the pituitary suppression has happened, and we can start with the gonadotropins. In long agonist protocol, the agonist is continued till the day of HCG. Now coming on to the long protocol started in the luteal phase. So in the luteal phase, we, as well as just like in the follicular phase, we can start it in the luteal phase also. So how we have to start in the luteal phase? From 21st day of menstrual cycle, once we have confirmed the ovulation. So once we have confirmed the ovulation, then we can start the GnRH agonist. Why? Why on day 21? There is a reason for that, because by day 21, all the hormones, the progesterone is at its highest. So the FSH and LH will be, because of the negative feedback, they will be at their lowest. So that's why we are starting the GnRH agonist at that time, so that the flare-up effect is minimized, and the corpus luteum, which is already present on day 21, that does not become cyst, that does not enlarge, and that does not become cyst. So that's why on day 21, after confirmation of the ovulation, we start with the GnRH agonist on day 21. Now, as I told in the follicular phase, by 10 to 14 days, the pituitary suppression will happen, and all the methods which I already told, we will be doing that, hormonal as well as the ultrasound. And once the pituitary suppression has been confirmed, we will start with the gonadotropins, and GnRH agonist is continued till the day of HCG. So this was about the long protocol, follicular as well as luteal. Coming on to the short protocol. In the short protocol, the GnRH agonist is started from the second day of menstrual cycle, and GnRH and the gonadotropins, that is the FSH or HMG, they are started from the third day of the menstrual cycle. So that is the only difference. Both are continued till the day of HCG. There is why the short protocol, it is followed in the patients with decreased ovarian reserve, because the flare-up effect, it helps in the follicular recruitment. Ultra short protocol, the only difference between the short and ultra short protocol is, in ultra short, we are giving the GnRH agonist only on day 2, 3, 4, and after that it is not given. Gonadotropins are continued till the day of HCG. Microflare protocol. In microflare protocol, the leupride is given in the low dose, that is the 40 microgram twice a day. So it comes out to be 80 microgram, and it is continued till the day of HCG. So the difference between short protocol, ultra short protocol and microflare protocol are based on the agonist. In short protocol, we are giving it on starting from the day 2 till the day of HCG. In ultra short, day 2, day 3, day 4, and in microflare, the dose of the leupride is very less. So this was all about the agonist protocols. Now coming on to GnRH antagonist. What is antagonist? The antagonist, it leads to immediate pituitary suppression. So there will not be any flare-up effect. So there will be immediate pituitary suppression. So what are the protocols which are available? Fixed protocol and flexible protocol. What is the difference between fixed and flexible? The fixed is, we will be starting the GnRH antagonist for pituitary suppression on day 6 of the stimulation. So once the stimulation is started from day 2 of the menstrual cycle or day 3 of the menstrual cycle, on the 6th day we will be, irrespective of the size of the follicles, we will be starting the GnRH antagonist. And what is the flexible protocol? It depends on the size of the follicle. Once the leading follicle has reached more than 14 mm, the GnRH antagonist is started. So there is no difference in pregnancy rates based on the fixed or the flexible protocol, and either of both are equally recommended. So what are the preparations which are available? Mostly cetotrelix and ganirelix are the one which are used. If we are using daily injections, that comes in the dose of 250 micrograms or 0.25 milligram. The depot preparations, they come in the dose of 3 milligram. In clinical use, we are using daily injections, 0.25 milligram. So now coming on to GnRH antagonist protocol, what it is. So in GnRH antagonist protocol, from second day of the menstrual cycle, gonadotropins are started. And then either on the day 6 of gonadotropins or when the leading follicle reaches 14 mm, as I explained, depending on the fixed and the flexible protocol, GnRH antagonist is started. And both are continued till the day of HCG. So this is what the GnRH antagonist protocol is. It is the simplest protocol to follow. It is not as complicated as GnRH agonist, and it is a very short it is completed in less than 2 weeks. While GnRH agonist, it might take more than 3 weeks or sometimes maybe a month. So that's why GnRH antagonist has come out to be a protocol which is easier to use, and it is more patient friendly, and it includes less number of injections. So now we will be comparing the GnRH agonist and GnRH antagonist. What are the difference between both? GnRH agonists, they act by down regulation and desensitization of the GnRH receptors, while GnRH antagonists, they act by the competition. They are GnRH receptor competitors. GnRH agonists, they suppress LH release after flare-up. So there will be initial flare-up, sometimes which can lead to cyst formation if we are not starting the GnRH agonist in the follicular phase. But GnRH antagonists, they will immediately suppress the LH without any flare-up effect. So that is one of the advantages of GnRH antagonist. GnRH agonists, they are administered by subcutaneously daily, or even depot preparations are also available, and same is true for the GnRH antagonist. Then why GnRH agonists are still in the market? Because there is one added advantage of GnRH agonists. They give a very synchronized cohort of the follicles. While in GnRH antagonist, mostly it happens that the follicular growth is asynchronized. What is meant by synchronized and asynchronized? Some follicles will be like 14 mm, some will be 10, some will be 10, and some will be very small. So this happens with the GnRH antagonist. While with GnRH agonist, all the follicles will be mostly they will be of the same size, because initially pituitary suppression has happened and gonadotropin withdrawal has happened. So that's why when the stimulation is started, all the follicles follow the same kind of growth. So that is one of the advantages of GnRH agonists. And second advantage is we can always schedule, either we want to postpone the GnRH, either we want to postpone the retrieval ovum pickup process, and so that's why we can schedule our retrieval timings accordingly. While in GnRH antagonist, we cannot do that. If the patient is prepared, we have to take the patient for the retrieval. So the scheduling process is not possible with the GnRH antagonist, while it is possible with the GnRH agonist, because we can start the gonadotropin stimulation as and when. It will not matter if the pituitary suppression be prolonged by a week or maybe 10 days, it will not matter much. Only dose of gonadotropin might increase, but that is one of the added advantage with the GnRH agonist. Okay, so I hope this was useful, and please tag me if any queries arises after with this PPT. Thank you.